Hello, dear colleagues. Welcome to this joint webinar of the EANS functional and pediatric sections, where today's experts will discuss surgical strategies in focal cortical dysplasia. With me, I have Dr. Daniel Nielsen, who works as a pediatric neurosurgeon in Göteborg, and Dr. Olaf Schens, who is an epilepsy surgeon in Maastricht. We have as our first speaker, Dr. Thomas Blaublom, a pediatric epilepsy surgeon at the Hôpital Necker in Paris. And as a second speaker, Professor André Palmini, who is an epileptologist in Porto Alegre in the south of Brazil. And one thing that I want to mention before we get started, that I want to encourage you all to actively participate by writing down your comments and questions in the Q&A box. We have a discussion after the first and the second lecture, so you can pose your questions at any time, and I will check these regularly. So Thomas, please go ahead.
Okay. Okay, is it working correctly? Super.
Yes, it's fine.
So good evening, everyone. So I'm Professor Thomas Blaublom. I'm the head of pediatric neurosurgery in Necker Hospital in Paris. The aim of this topic is to give you an overview of what is a focal cortical dysplasia, to give an update of the ILAE classifications, and to give strategies, or at least to begin to think about strategies that will be developed more in details in the second talk by Professor Palmini. So just to start, an illustrative case of what we are facing with when we're talking about focal cortical dysplasia, it's epilepsy with seizure that will start early in life, like in this kid who had his first seizure at age 3. In this case, you see it's focal seizures with sensory and motor symptoms. Typically, it's drug resistant. In this case, 7 anti-seizure medications were started. And you closely have a look, you can see that he will have motor manifestation on the left arm that help to localize actually the seizure onset. Despite the EEG is not so informative in terms of localization. It gives you a regional overview of where the seizure are starting, but it does not give you the sweet spot about where the seizure started. The initial imaging was considered as normal, despite PET scan showed a slight hypometabolism in the central sulcus. Neuropsychological evaluation was normal, and genetics did not find any germline mutation in this patient. So the first thing we did in this case was to go back actually and do again the MRI and do again the PET scan, because we had a strong feeling that there was a lesion actually in the sensory motor region. And here you can see that there is an abnormal sulcus at the junction between the SMA and the cingulate gyrus that is clearly seen onto the PET scan imaging, and that post-processing of the imaging with MELD that we will detail later on helped us to localize. However, it was not possible in this particular case to go for surgery straight ahead, and we had to go for invasive recordings, and we will have a quick talk about this. The invasive recording was made to explore the sensory motor area with somesthetic and motor cortex exploration, along with the paracentral lobule, SMA, and the insular cortex. This is what you can see during the SEEG. And the interest of the SEEG is that you have a very precise delineation actually of the ictal onset zone that was really restricted to this sulcus that you can see here displayed on the MRI, but it's very focal at the beginning. If you do cortical stimulation, you can use 1 Hz or 50 Hz stimulation of the intracerebral electrodes, and it's possible to reproduce actually the seizure while stimulating at low frequency, low stimulation, the contacts that were located precisely on the green area on this MRI. So this is a supplementary argument to go for surgery. And the summary of this SEEG is that there are abnormal sulcus on the MRI, irritative zone with interictal continuous spiting on a very limited area of the brain that is therefore amenable to surgery. And as you can see here, surgery is greatly helped by the use of intraoperative navigation with image injection inside the cortex. What is important with surgery is that you will use anatomical landmarks, which are the sulci for this patient. So this is the midline actually that was exposed, the premotor area, and you will try to achieve resection until the sulci limits, and to try to find this very particular area for FCD type 2B, which are very firm on orange tissue actually inside the FCD. So in this case, it was not possible to do en bloc resection. We had to use the CUSA and to do piecemeal resection. But the aim is to find the limit, actually the anatomical limit. As you can see here, we did not use intraoperative electrocorticography, as we relied on extraoperative electrophysiological mapping with the SEEG. So histology said this, FCD type 2B. But here we are talking about focal cortical dysplasia. So what is a focal cortical dysplasia? If we go back to history, actually, it was described more than 40 years ago by a team in England that showed that in 10 patients who had focal seizure with a young age onset, during surgery, the guys did lobar resection and they were able to find always the same feature on the histology, which was a disorganized architecture of the cortex, presence of giant neurons plus multinucleated cells, the so-called Taylor neurons, actually, that we are still using as a critical landmarks to use the diagnosis. Since this early description in the late 70s by the team from Taylor and Falconer, there have been multiple refinement of the classification that try to incorporate actually the knowledge about corticogenesis. So there is currently the classification, and I will not go back to the past classification. Maybe Professor Palmini we talk about it. But the current classification of the focal cortical dysplasia is the following. You have 5 subtypes of focal cortical dysplasia among the surgical series, which are the type 1, type 2, type 3, mild MCD, and the recently described MOG. What is important to note is now the WHO plus the ALE, the International League Against Epilepsy, wants to talk about an integrated diagnosis. It takes into account the histopathology, the genetics, plus the imaging. And inside this different subtype of focal cortical dysplasia, you have at the end only 2 subtypes that are clearly defined with molecular abnormalities on the mTOR pathway for FCD type 2 or for SLC 35A2 for the MOG. And I will now detail each subtype of the focal cortical dysplasia on how they behave on a clinical point of view. The first one is the FCD type 1. FCD type 1, on the histopathological point of view, are marked by a cortical disorganization. So it's a loss of the normal architecture of the cerebral cortex that can either be a microcolumnar organization or loss of the normal tangential lamination. So here is an example with a newer-N immunostaining of FCD type 1A, where you see that the cortex looks too well organized. You see these microcolumns, and this is clearly the hallmark of the FCD type 1. You have a radial dyslamination with microcolumns. On the other hand, here with this FCD type 1B, you see too well the lines, the layers of the cortex, and in this case, you have the layer 4 that is missing, and this is called tangential dyslamination. That is the hallmark of FCD type 1B. And if you have both microcolumnar and tangential dyslamination, then this is called FCD type 1C. How does this correlate to the clinical symptoms? Well, it's not so easy. There is not a clear-cut clinical expression of the FCD type 1. The seizure semiology will clearly depend on the age, the location, and the extent of the disease. And one of the main points is that this disease is not very well limited, both on the imaging, both on the histology, but also during electrophysiology. What is really important is that often these diseases are pretty widespread, expressed early during development, and encephalopathy with spasm may be one of the clinical expression of this disease. And the asymmetry of the symptom is one of the really important features that will help you to distinguish this FC type 1 from other encephalopathy. It's resistant to the anti-seizure medication, but there is no clear EEG characteristic pattern. If you look for the MRI, this is also really complicated because it's very subtle. There is a global hypersignal in T2 and FLAIR images of the white matter, but mostly the hemisphere or the lobes look hypoplastic if you compare it to the other side. So it's really subtle. It's not a clear syndrome, and it's really variable from one patient to another. And what is important is that no somatic genetic mutation have been identified so far associated with this disease. Recently was extracted from the FCD type 1, the MOG, because it's really characteristic. And there is something that is more easy to define in this patient. If you look for the histology, you have here the OLIG2 immunostaining that display an increased density of oligodendrocytes in this patient. You have more than 2,200 OLIG2 cells per millimeter squares during the MOG. It's associated also with heterotopic neurons in the white matter, and this is what you see here in this MAP2 immunostaining. Here you have a normal patient, and here you see heterotopic neurons in the white matter. And the last thing is that you have vacuolization in the white matter that you see with this kind of holes actually in the white matter. Interestingly, these lesions are mostly found in the frontal lobe areas, and they are seen with a cortical thickening associated with the blurring between the gray and white matter. But it's not very localized. Generally, it's more a regional features than a gyral or precise feature. What is interesting with this patient is that genetics from the cortex that you will operate will find a somatic variant in SLC35A2, which is actually associated with the glycosylation process. So this disease actually is druggable. There are trials emerging with D-galactose supplementation, and this is to take into consideration when treating this patient if there is surgical failure in order to treat the seizures, because supplementation in D-galactose may help actually to control the seizures. The clinical entity that is the best actually defined is FCD type 2. Why? Because it gives focal seizures more than encephalopathies in children. It's really more about focal seizures. This is the patient I showed, and this is really what most epilepsy surgeons are looking for. It's this patient with very focal seizures that are associated with a focal malformation of cortical development. The EEG pattern is really characteristic for this patient because you can record either on the scalp, on the surface EEG, but also on the intracranial EEG, either during acute recording in the OR or outside the OR, subcontinuous interictal spiking. And this is, I think, from the paper from Professor Palmini or from Francine Chassou that now go back more than 20 years ago. But this is really the characteristic of FC type 2B. When you have the electrode inside the FCD, it's firing all the time with interictal spiking. And this is not seizure, it's interictal pseudo-continuous spiking. Looking at histology, The hallmark of FC type 2P is that you have abnormal cells, cytomegalic neurons, which are very large neurons associated with cells that have both a neuronal and astrocytic phenotype, which are called the balloon cells, and which are the hallmarks of FCD type 2B. And what is interesting is that if you use immunostaining for phospho-S6, S6, these lesions will stain very densely for phospho-S6, which is a hallmark for the mTOR activation, because these FC type 2B are secondary to mTOR somatic mutation in the brain. And this is the only FCD actually that is very well characterized on this level, because all mTOR pathway, starting from PA3K, PTEN, DAPDC5, TSCGen, REB, can harbor mutations that will end up with constitutional activation of the mTOR pathways. And what will give the phenotype actually in your patient along to the gene by themselves is the moment in the cortical neurogenesis where it appears. And the earlier the gene, the somatic mutation will appear, the more widespread the mutation will be. And you can have an expression that can be very localized, like this so-called bottom end sulcus focal cortical dysplasia, that are very localized until malformation that will interest a whole hemisphere, like in hemimegalencephaly. This is the same mutation in the brain occurring at different time in cortical neurogenesis. So talking about strategies, all these focal cortical dysplasia lead to drug resistance. This is really a hallmark of malformation of cortical development. Generally, during 1 year after diagnosis, drugs will fail. So surgery is clearly indicated in this patient, but as you can see, overall follow-up at 5 years is only around 60% of patients who will be seizure-free, with predictive factor being complete resection on the presence of a lesion on the MRI. So how can we improve these results? Can we have very good strategies to deal with patients with focal cortical dysplasia? I think for me there are a couple of things that we need to take into account. First is the age of the patient, because seizure semiology will vary accordingly to age. The myelination of the cortex explains why seizure semiology can change according to age. But seizure semiology can also be associated with the extent of the malformation, and therefore epileptic encephalopathy associated with asymmetric spasm is not per se a contraindication to the surgery. It will give you a clue that the disease is more widespread, but it's not a contraindication to go to further explication. So seizure semiology is associated with age. It's associated also with the extent of the disease, but it's also associated with the pathologic process, as FC type 1 tend to be more associated with epileptic encephalopathies. What is really important after this is to try to define the limits of the lesion using EEG, imaging, and to try to find an agreement actually between the MRI, the PET scan, and the EEG in order to have the limits before we go to surgery. And if these limits cannot be achieved, you need to go with invasive recordings. Next thing to tailor the surgery is to take into consideration the anatomical extent of the malformation. This can be very localized for the bottom end sulcus FCD, but this can also include a whole hemisphere. So the type of surgery can go from very focal resection actually to hemispherotomies. Lastly, I think we need to take into consideration now the genetics, because it can predict the outcome of the patient, because outcome of patient with FCD type 2B is clearly better than patient with FC type 1, but it can also guide targeted therapy in case of failure after surgery, for example, for the patient with the MOG. But what is of utmost importance actually in focal cortical dysplasia is to use a multidisciplinary meeting. You need a great pediatric neurologist or neurologist in order to eliminate differential diagnosis. You must not operate a Dravet syndrome. You must not operate an encephalopathy associated with the channelopathies. And for this, you need a neurologist, a pediatric neurologist. Second thing you need is a neurophysiologist, someone who is able to locate and to do the association between surface EEG, seizure semiology, and the localization in the brain. A dedicated radiologist is also mandatory. You need to have someone dedicated to look and do second reading of the MRI. Neuropsychologist also, and genetics. So first, use dedicated imaging protocol. I think this is really important for FCD because if you look at the recommendation of the ILE, you need to use 3T MRI with a dedicated protocol using 3D T1, 3D FLAIR, axial coronal and T2, DTI also, and this increased by 18% the accuracy of the diagnosis. Second thing is, I think we need to use, and this is nearly mandatory for me, to use PET scan for this patient because FCD type 2B co-localize with the hypometabolism on the PET scan. And for example, this patient with a clear-cut hypometabolism on the PET scan does not need chronic recording. We can go straight forward to surgery for this patient, except the question of the functional localization of the motor area that we will need to delineate. I think another very important aspect currently is the use of IA and post-processing of the MRI. Something that has been brought to the community recently is the MELD. It's using either T1 or FLAIR, and it's extracting features inside the MRI, like the gray-white contrast, cortical thickness, the depth. But it can give nearly 70% of automated diagnosis of the FCD in the brain. And this is really important if you're in a center where there is no dedicated, for example, radiologist, because you can achieve automated diagnosis of the FCD, and it can also help you to locate the area you want to explore with chronic recording. It's also, for me, mandatory to use electrophysiology, and Professor Palmini will go in details with this, intraoperative electrocorticography or extraoperative electrocorticography. For me, the debate is not closed if you're chasing for interictal spikes, or high-frequency oscillation, but mapping interictal discharge in the OR really will increase the seizure freedom rate of your patient if you try to achieve the resection of areas that will give rise to interictal spike during the surgery. Alternatively, you can use extraoperative monitoring with SEEG, and there is a very particular pattern of the FCD that they are resistant to the benzodiazepines. So using diazepam, for example, during a SEEG help you a lot to delineate the very small areas that generate interictal spike that are resistant to the diazepam, and this is clearly of great help to delineate the FCD in this patient. If you don't have a very localized pattern, you used to use the philosophy of the SEEG, where you want to define the ictal onset zone, the propagation area, and in order to record the typical seizure of the patient, in order to answer to this question, is it focal seizures or is it a more widespread pattern? Lastly, SEEG now is also used as a therapeutic tool. You can use it for thermocoagulation, but it's also a great help because if you have like very small FCD during the SEEG recording, this patient can be amenable to percutaneous treatment, for example, with laser ablation inside the MRI. The extent of the resection will vary on all the preoperative examination, but it varies actually according to the extent of the disease. You can perform very localized resection like this bottom end sulcus dysplasia, lobar resection, for example, in this MOG, but you can also end up with doing hemispherotomy for this multilobar FC type 1, actually, that had a multilobar involvement during this SEEG procedure. So this is really preliminary introduction that I did, because we can go like in many details for the biology of the SCD, the basis of epileptogenesis, the philosophy of the SEEG, how we use intraoperative electrocorticography. But the main aim for me for this talk was to show that focal cortical dysplasia, or spectrum of epileptic malformation of cortical development, that have been classified recently by the IEE with an integrated diagnosis framework that take into consideration histology, MRI, and genetics. The only subtypes that has really a distinctive EEG MRI genetic signature is the FCD type 2B, and these are the ones that have the best surgical results. There are also the MOG that have emerged recently, but they are really more rare and they are less characteristic in their presentation. The surgical strategy will depend on the age of the patient, the seizure semiology, and the anatomical extent of the malformation. But above all, preoperative delineation of the FC is crucial, using MRI, PET scan, intraoperative, plus or minus extraoperative electrophysiological recording, because the delineation of the FCD is what helps you to perform a surgery that will lead to seizure freedom in the patient. And I thank you for your attention.
Thank you for this very nice and eloquent presentation. We only have one question from the chat box, so I will try to read it. The person states he wished to know the possible etiology, differential diagnosis, and surgical indications, if possible, of the different dysplasias, which is a general question in my opinion, but maybe you could talk a bit about the differential diagnosis. What do you also have to think about when you see something that looks like an FCD?
I think I don't see many actually differential diagnoses. There are a couple of ganglioglioma actually that behave a bit the same on MRI. But clearly, when you have this blurring, the differential diagnosis actually will be non-specific histology. You went for focal epilepsy, you end up with a lobar pattern, and the histology show you that you have unspecific changes associated with epilepsy. Generally, the patient is not cured. So clearly, this is, I think, the pitfall in this patient is to actually operate patients who don't have focal cortical dysplasia.
Maybe Daniel or Olaf, do you have any specific questions?
I have a comment and a question for you, Thomas. Great talk, really. And I think one pitfall or peculiarity of the dysplasias, especially in very young kids, is that sometimes they change when you are doing sequential imaging. So if you do an imaging when the child is maybe 6-7 months old, you might see the dysplasia and then it might disappear and then it might be seen again. Could you just comment on that? Have you also seen that? Or
yeah, I thank you very much for this comment. So this is very important because there is advanced myelination associated with FCD. So if you perform on a first MRI, like around 3 months, you will see the FCD as a hypo signal on the white matter. And this is really super helpful actually to delineate FCD type 2 or not FC type 1 because it matches super well with the hypometabolism if you go like for PET scan a few years after. And so very early MRI in this patient at the beginning of the myelination of the brain will show you advance in myelination that really match with FC type 2. But I'm not sure it's really helpful to, and you don't see this kind of process with FC type 1, with MOG. And MRI, actually, there is a blind window when the patient is around 12 months or 18 months, where the myelination is really a problem, and you don't see very well, actually, the white matter in these patients.
And I see another question from Professor Rössler now. Well, he has one comment where he mentions that if there are a few such lesions in very young children, one has to think about tuberous sclerosis, of course. And then he has one question for Thomas. He says, well, you said that FCD type 1 they have a MRI correlate? And is that really the case, he asks? So the type 1 dysplasias.
For TSC, I think it's a good question, but normally you should be able to see it before you do go for the surgery with germline actually genomic testing, because what we use is a panel of genes called epileptome actually in Paris, which includes of course TSC1 and TSC2. So normally you should see TSC2 mutation plus there are extra neurologic signs of TSC, plus generally you see the tubers and there are many tubers in the brain. So that's the first question. Regarding the MRI pattern of FCD type 1, I think it's really difficult. They're trying to use actually post-processing MRI features to extract FCD type 1, and for the moment it's not a great success because it's really non-specific. You have really, they kept actually FC type 1 as an entity in the ILE classification, but I'm not sure that in 5 or 10 years, this is something that will stay. And I think the absence of genomic diagnosis in this patient explain the different phenotypes within these patients.
Andre, do you want to comment on this maybe? What do you think about type 1 dysplasias? Should they be, should we get rid of them from the classification or not?
No. Listen, well, that's not the point, the main point of the discussion, the classification itself. I think that the class 3 could perhaps be taken away from the classification. Type 1 does exist, and I think that it was very nice what Thomas showed, that this is what Hans Holthausen has been shown, this shrinkage of the subcortical white matter in connection with some increased signal that sometimes extends the whole axis of the temporal lobe or temporal parietal, temporal occipital. I think that we can rely on that for at least for this small kids with the severe epilepsies. What I have more difficult is this cortical lesions that eventually come back with type 1A FCD. There's a paper coming out in epilepsy from Ingmar Blanke's group showing that sometimes you see that, but you see that only because that's what the pathologist got. You see, if you can go more in depth, you see that sometimes you have some dysplastic neurons that eventually that will be type 2A. Okay, so I have a difficulty with type 1 in the neocortex, like the frontal central parietal. I don't have too much difficulty with this thing that this entity that Hans Holthausen described, which is temporal occipital, temporal parietal occipital, large lesions with predominantly posterior quadrant with this very severe encephalopathic pattern and shrinkage of the subcortical white matter. And I think that Professor Thomas showed 1 or 2 cases like that, right? I think one of the cases was more difficult to identify, very difficult to differentiate from Mogio, for instance, your in the imaging, your example there. But there was another case that was a shrinkage of the temporal lobe white matter, and I think that suggests much more type 1, I think.
Yeah, and I agree that the posterior quadrant location is really more associated with the FCD type 1, but I mean, it's...
Or at least one subtype of FCD type 1, which is a type 1A, see, the vertical microcolumns. I have difficulties with type 1B and type 1C. That seems more like a theoretical construct than something that you really see, in my opinion, I don't know. Let's see how it will show up. But I think that for the time present, you can really suspect type 1. In this case, you showed with the posterior quadrant. That's my impression. The others will be like a microscopic diagnosis that you wouldn't know. It would come type 1 or type 2A. I think that sometimes you have these doubts.
I see there is another question for Professor Blaublom. Could you give more detail about high-frequency oscillations? Is it a reliable data for delineating epileptogenic zone?
Well, so there was a great hope because the UCLA group, so this is oscillation between 250 Hertz and 500 Hertz. And Gary Matern and the UCLA group showed very nicely that it matched with the area of FC type 2B. So there was a reasonable hope that resecting areas with HFOs could link to seizure freedom in this patient, because there was like a very a good correlation between histological abnormalities and this high frequency oscillation. But the prospective trial actually from Utrecht was not so clear actually. And this is a prospective trial comparing the use of HFO on apparently interictal spikes. Removal shows better results than HFOs. So I can't say more because I'm not lucky enough to have intraoperative HFO detections. So I have no personal experience with this. I don't know, André Palmini, if you want to comment on this, but I think what is important is that with FCD type 2, I think my message would be that interictal spikes are really a good marker of the lesion, which will not be the case actually on of the geographic extension, which is not the case actually in the other subtypes of FCD, where you will need to rely on a more global picture and mostly with ictal data.
Right. Thank you.
Okay, so
perhaps,
maybe should we go on to the next speaker?
Daniel, when it's possible, I just have one short question for Thomas, and that is, do you think there is a role for a resting state fMRI? So there are some reports showing that the bolt signal around FCDs is a bit more larger than the FCD itself, so indicating perhaps a bit larger epileptogenic zone. Do you know something, or do you use this fMRI, resting state?
So yeah, we used it on one of the radiologists did a postdoc actually in the Netherlands for something called regional homogeneity, which actually looks at the resting state fMRI data. And we used it actually in, I think, in 15 patients with FCD, with multimodal imaging. It's really sad, but the best sensibility and specificity was achieved by PET. And what is really interesting with this, because the data were acquired on the 1.5 Tesla, not on the 3T, but we went back with this data set with the MELD, and the MELD actually achieved nearly the same score as the PET scan. So it's really complicated actually to treat this data of resting state. We also use the EEG fMRI to link the spikes plus the bold effect on everything. But the best result for us were using combination of PET scan and MELD, and it's really simple and robust to use. So,
okay, thank you.
Okay, so I will introduce our next speaker, which is, I would say, a living legend in the epilepsy. It's Professor André Palmini from Porto Alegre in Brazil, and he has been working with dysplasia for many years, and you wrote the first, also the 2011 ILAE classification, also was a big part of the latest classification. So please, André.
Thank you very much, Daniel, for this nice introduction. Thank you also, Tom, and the colleagues for the invitation. Before starting my slides, I think that Professor Thomas's talk made it clear that we have to start thinking about focal cortical dysplasia as we learn to think about temporal lobe epilepsy. In the beginning, it was temporal lobe epilepsy, period. Now we know that you can have temporal lobe epilepsy with hippocampal sclerosis, temporal lobe epilepsy with cavernomas, temporal lobe epilepsies without visible lesions. So we have several types of temporal lobe epilepsy, several subsyndromes, and each one has to be treated differently. It's the same thing, I think, with focal cortical dysplasia. I think it was very clear that when we think about FCD, we usually just throw the term focal cortical dysplasia. But there are several different diseases from different genetic backgrounds, different lesion extents in the neocortex, and then an involvement of subcortical white matter. And of course, this has to be thought in a different way. So I think that it's, and also, for instance, you can have lateral neocortex, mesial wall. All this suggests, at least in our service, we have a very good experience with this here, that you have to treat every patient as one patient. So this thing of FCD, how do you manage FCD? You see, as a general approach, is perhaps not the most suitable one. We have to go case by case, because according to the scenarios, you can try to anticipate underlying histopathology, what you may expect in the intraoperative ECOG, what you may expect in terms of extent of the lesion, and these, of course, will dictate the approach. So I think there are different kinds, not only from the classification, it's an obvious thing, but that suggests that we shouldn't just think, is that dysplasia? It doesn't mean too much things. For instance, you can have many patients FCD2A, as I will show you in a second, that you already know that you have more extensive abnormality versus type 2B, which you know will be very restricted. So just saying FCD2 doesn't really make too much sense nowadays. You already know that you may be dealing with different entities from the surgical perspective, okay? And I think that this is something that more and more people should realize. Let me share my slides here. Is that okay, the slides? Okay, so I would like to make one point here, you see, which is that, of course, there is no dispute. Nobody, I think, that would dispute that intracranial stereo EEG is a most fantastic tool to identify epileptogenic zone, areas of early propagation, and to delineate that three-dimensional area of abnormality. That's clear. However, I've always been worried, you see, with one thing I learned from Professor Engel, who's been sort of my second mentor. You see, I have been mentored by Frederick Anderman and by Engel. And Engel, as you know, is somebody who was always very interested in epilepsy surgery as a tool that could be used universally, not as a boutique approach, but something that really would help people all around the world, okay? And if you have this broader view, this broader view, you have to also understand that some more sophisticated methodologies of evaluation may not be available to everybody. So from our beginning, because I was trained in Montreal, and Montreal didn't have the SEG culture. They had the ECOG culture, and Professor Olivier used to put 3 or 4 intracerebral electrodes that didn't really amount to SEG, you see? That was like one in the amygdala, one in the anterior hippocampus, one in the posterior hippocampus, one in the orbital-frontal, one in the middle of the frontal lobe going into the cingulate, and that was it, you see? So I learned from scratch about the intraoperative ECOG, and we have been trying to improve this over the years in a way to really have this as a less expensive, effective tool to define the extent of resection. And that's exactly, and that's mostly the point of my talk here, okay? Let me start by sharing my slides, okay? And I would like to start with a concept that is a Montreal concept from Theodore Rasmussen, which is the concept of the relevant epileptogenic tissue. I had the chance to review all this literature in a paper published now almost 20 years ago in a review in epileptic disorders. But this is, I quote verbatim from one of Dr. Rasmussen's paper. Third-order localization of epileptic phenomena concerns primarily the decision in the operating room as to how much of this potentially that I call relevant epileptogenic cortex must be removed to produce a satisfactory reduction in the patient's seizure tendency. So he really incorporated this idea that in the end, during the operation, guys like you, neurosurgeons, I'm a neurologist, okay? But I have been with my brain divided today because we're having an operation here in the hospital right now that's still going on, have to decide how much to resect, okay? And this is something that I believe the acute ECOG may be very helpful, particularly the ECOG we use which is the same used in Montreal and not used in many other places, which uses this flexible 16 or more ball-pointed electrodes that you can move around as much as you want. And then it's one way that we believe you can go after what I call the relevant epileptogenic tissue. And what I mean by relevant epileptogenic tissue is by epileptogenic tissue that may not be so related to seizure generation at the moment you operate in the first time, but eventually may become. As I will show you later, we have about 20% of patients that failed in our series, 30% of patients that failed, but that seizure recurred following 18 months of seizure freedom, showing that some parts of this epileptogenic zone may be left behind and be silent for a while until it starts generating seizures. And we believe that acute ECOG may help to identify at the operation this tissue that may cause problems sometimes later, and that's what I will try to show you now, okay? So let me start by the way we do this, okay? This, let me just see, you see, these are the electrodes I mentioned. These are not grid electrodes that most people, I think that probably Professor Thomas showed one example there very briefly with this, grids, you see, ECOG with grids. That gives you just the approach of the surface of the brain, okay? And as we know, an FCD lesion goes very much into the depths of sulci, and you can see this, what the surface of the brain shows in this particular patient, okay? Continuous spiking, this was already very well shown by Thomas, okay? And then you see, I mean, sometimes we even discuss, is this ictal or interictal? It's interictal, but it's continuous, okay? And then you resect it. But then you see that you may still have spikes that you would perhaps wouldn't have paid too much attention. But then if you can explore the depths of the lesion, like we're doing with these flexible electrodes, then you identify areas that you continue with spiking, and then you resect it. Sometimes you can go and then you explore. You see, here you don't have too much, but here you really explore a little bit more, and you see an area which continues spiking. If you leave this here, even if seizures don't come back in the first 6 months, they will come back. Clearly, they will come back, okay? So we have data that as much as you resect of these areas is continuous or rhythmic spikes, the better for the outcome, okay? So that's the way we approach this. And then in the end, we leave it like this, okay? So this is one of our picks. The way we go after this is that we try to use imaging, and by imaging, I mean mostly MRI and PET, and try to identify this, okay? So here you have one of these patients, which is which nicely shows the thing that have been said, that you can have dysplastic neurons or even balloon cells outside of the main visible lesion. Few would dispute that you have here a very clear increase in this cortical thickness, okay? But then if you see in that particular area where the cortex is thick, okay, and blurred, you have many balloon cells, etc., and you have these frequent electrographic seizures from here. But after removing this, you see, you go into the vicinity, and in the vicinity, you don't have really the same kind of increased thickness, but you have also areas with frequent spiking, and then you go into that area in the pathology, and you still have balloon cells and dysplastic neurons. That's what I call the localization of the relevant epileptogenic tissue. I'm sure this could be done by SEG as well. You would have electrodes in these areas. But what I'm telling you is that by intraoperative recording with these flexible electrodes, you can move from one place to the other and really explore the area of the craniotomy. You can identify these types of patterns and try to do as much a large resection as you can within functional constraints, of course, okay? Let me follow this. This is another patient which was very interesting case. You see, this psychologist had this lesion in the left frontal lobe, this dysplastic abnormality, okay? And in that area, we had spikes and we had dysplastic neurons, it was very clear. But as you see here, after we resected the first part, we went back and in the vicinity, there was still an area with this, you see. I'm not so sure if this would show up as so well in an SEG recording in terms of seizure generation, because most seizure probably would come from the area that she had most spikes in the beginning. But then you also had this, that interesting enough, in the beginning, you didn't have too many spikes here. But after you resect part of the lesion or the visible part of the lesions, sometimes microscopic abnormalities that didn't show up in the MRI and even didn't show up in the beginning of the acute ECOG will then show up with these polyspikes and very rhythmic abnormalities that also had dysplastic neurons. So the kind of patient that if we had not explored intraoperatively, we would perhaps have left this area behind and seizures would surely return, okay? And that's what I call the relevant epileptogenic tissue. My final example is this girl, you see. She was referred to us because the people wanted to use grids, and eventually they heard that we could perhaps try to help her without grids. You have this premotor blurry here. Everybody can see this, okay? And I mean, lo and behold, she had this frequent spiking and intraoperative acute electrographic seizures you're seeing here, okay? Then you resect, and then you go back and you see some more spikes, you resect everything, and these patients get well, you see, because you can sort of clean up not only the areas where you have this very frequent spiking, but surrounding areas where you have spikes that clearly are going to be relevant in terms of in the long term. That's what I strongly believe, because when we leave these other spikes behind, these areas spikes behind, many times seizures recur in the long run, may not recur in the first 6 months. You may be very happy after 9 months, after 1 year, but sometimes later on, as you see, seizures will return, okay? So the way we do it is what we call the intraoperative sequential exploration with flexible ballpoint ECOG electrodes. And we believe this has a relevance in the context if you can associate this finding with preoperative non-invasive data, okay? So it's very important when you use acute ECOG that you don't think that acute ECOG, and this is a different paradigm from SEG, the acute ECOG will give you all the answers. Preoperative non-invasive data, when you use SEG, is mostly used to define the targets of your electrode placement, period. After that is decided, then you go on and you do a resection based upon SEG. Here it's not like this. You know that ECOG cannot explore, for instance, everything in the brain, cannot explore mesial wall. It's very difficult, of course, the mesial wall. And so you incorporate this with the other data, particularly, of course, semiology, PET, and MRI, okay? So in the end, the ECOG gives you part of the answer, but you are not going to be restricted by ECOG if you have, for instance, clear-cut ideas. I will finish with a case like that perhaps the area involved will be a little bit more extensive than what the ECOG shows. And then you incorporate that from your knowledge of functional anatomy of the brain, semiology, and scalp EEG, okay? So in fact, what we do is the integration of data between semiology, scalp EEG, imaging, MRI, and PET, I forgot the PET, and after this, you decide which is the area of the brain I will explore acutely, and then you go there with the ECOG, okay? This is the apparatus we use, and of course, to identify this relevant epileptogenic tissue, we take many aspects into consideration. The frequency, the rhythmicity, the morphology of the spikes, sometimes these polyspikes are very, very epileptogenic. The associated background abnormalities, sometimes like this patient is just being operated now. You see, the bulk of the dysplastic area had an attenuation of the signal, you see, and the surrounding area, which was not so obvious the lesion, had this very frequent spiking. So you have to incorporate all this information into the final decision of the resection. So it's one tool to help localize from what you already had in non-invasive studies, and then you refine this intraoperatively, okay? So the main point is that in focal cortical dysplasias, the relevant epileptic tissue must contemplate, of course, epileptogenic abnormalities beyond the obvious area that you see on the MRI sometimes. And how to delineate this relevant epileptogenic tissue is the crucial issue, because as you saw, and many times we see this, and I'm sure all of you have seen, sometimes you have dysplastic neurons. Outside of the area, you can see a visible lesion. So, of course, you have to explore this in a way or another. Of course, ECG would be the gold standard, but you cannot use ECG for everybody. You see, I mean, it's if you imagine, I think, if in Europe, 50%, let me just throw a number, 50% of patients with focal cortical dysplasia, type 2, for instance, are operated following ECG evaluation. In Latin America, it's 2%. But I mean, in Latin America, you have perhaps as many people as you have in Europe. So you have to have a way to operate these people here. Otherwise, you'd say, well, you see, unfortunately, you cannot do this because we don't have ECG. So we have been trying in Porto Alegre, and we now have many things sent to publication that hopefully will show up in this next year. You see, both conceptual and data, to try to do the best with what is possible for us to use, okay? So what we do this in the end is to propose that a careful integration of seizure semiology, scalp EEG, and high-resolution imaging, particularly PET plus MRI, is often sufficient to circumscribe the epileptogenic network to a given cortical area, and then we go there with ECOG, and with acute ECOG, we define the limits of the resection. We have, this is what we just sent to publication, 5 patients, all extratemporal FCD2 visible lesions. These are FCD2 visible. Of course, if you have normal MRI, you cannot go with ECOG alone. I mean, you're probably going to be missing the lesion. And then, of course, you have to go into a different direction. But if you have a visible lesion, which is very often the case, we have been this series that are explored with the way I just showed. We had 76 patients because 9 were lost to follow-up. And there were a division between FCD2A and 2B. And of course, the outcome in 2B is much better, and that has already been shown today. In FCD2A, it's about 50% class 1. FCD2B is about 72%, because these are areas that you can usually have a better idea of the way to resect, and the abnormalities are usually contained in these areas of normal signal, okay? But that's important thing. You see, 38% of our patients which recurred, they recurred late. So that's what I mean by this relevant epileptogenic tissue that sometimes are left behind, are part of an area that is not causing seizures at the time that you operate, but you leave some area behind that eventually will lead to recur, and sometimes it's a late recurrence. We have up to 7 years recurrence, so say 7 years seizure-free, and then starts again. This sub-analysis of 66 patients longer than 5-year follow-up shows clearly the other obvious point, okay? If you have abnormalities, dysplasia abnormalities in indispensable cortex, like Eliseo Paglioli likes to say, I mean, not only relevant, but indispensable, then of course your results are worse. So there's a clear relationship between class 4 and this kind of lesion location versus the other side. And this has also been shown in this MELD study that was mentioned by Thomas, okay? So if you look into the results, you see, results show clearly that depends on the area that you have the most abnormality, you have the result. It's interesting here, you see, the worst percentage of seizure freedom, which is this dark color, is exactly, for instance, in motor premotor areas, as you would expect, okay? So the main premise of acute ECOG in the delineation of the extent of the lesion to be resected is that the acute ECOG goes hand in hand with the experience of making the best of non-invasive data. Of course, you can only use this if you can manage well the non-invasive data, including semiology, okay? Because then the method provides what we call a flexible coverage, and then we'll tailor resection according to sequential recordings of the acute ECOG. Okay, there are this advantages. One of the important advantages of this kind of spider like electrodes is that you can explore the depths of the gyre and do as many electrorefusions as you want during the operation. Okay, I'll finalize with this slide of this boy. Okay, showing the integration between semiology, PET, and acute ECOG. COC stage 4, or as blurring of vision, scintillating scotoma's right visual field. The seizure would evolve into disconnection, automatism, some seizures like that. Other seizures had an eye deviation to the left side, which was ipsilateral to the lesion, and very often suggest parietal involvement. So we had this occipital lesion with some semiology suggesting parietal involvement. Okay, and then you have this PET, which is more widespread, involving also perhaps the posterior temporal hypometabolism, and this EEG, which is of course mostly localized in the left occipital lobe where the lesion was, but also in the monopolar montage, some extent to parietal and posterior temporal, and then you organize a resection according to lesion plus acute ECOG plus semiology plus EEG, and then you do a much larger resection than the lesion, and in this particular patient, also larger than what the acute ECOG showed, and we believe that's the way you use it. You see, it's not a definitive tool, it's a tool that we incorporate with these other non-invasive methods, but has been able to provide for our patients a very good results. Okay, I'm sure some of our patients would perhaps have done better if we could have done SEG, but many patients, you achieve the same result with one method or the other, particularly if you can also learn how to do this intraoperative localization of particularly the primary motor cortex, that we do that with intraop cortical stimulation. And then we try as much as possible, of course, with our surgeon, trying to spare underlying white matter, etc., and try to have as good results as we can. So that was the main point I would like to throw to discussion, okay? Because there are different ways to go into this, particularly if you consider FCD not as an entity, but as a group of entities. That was very nice shown by Thomas. And as a group of entities, some of them, I believe, you can go non-invasively. Others, you have to really think twice. For instance, if you have more extensive lesions, perhaps you have to explore them. Hans likes to explore them with intracerebral electrodes to see the extent of distribution of lesions. So I don't believe there's a final word for this. But what I do believe is that more and more you have to help these people. This boy who we're operating now, I just got this message from the OR that they are finishing the resection and now going to do this second part of the ECOG. I mean, this boy was seen as somebody with West syndrome, and apparently it was idiopathic cryptogenic West syndrome, because you were discussing the MRI in the very early age. He had an MRI record around 1 year of age, and that was read as normal. But you should never, I'm sure that everybody that's here with us now know that you should never believe too much in MRI reports, okay? Because you're the one seeing the patient. You know what that patient has clinically, and the radiologist doesn't know this. Of course, if you can sit everybody in the same room in the conference, epilepsy surgery conference, it's one thing. The other thing is you receive a report in your office, okay? That person doesn't know exactly what's going on with the patient, but you do. And this boy had a clear abnormality in the left posterior quadrant, and I'm sure he'll be much better, and he'll be perhaps in a different trajectory than if you were like just treated medically. So thank you very much for the opportunity to discuss these issues with you.
Thank you very much, Henry. It was great, and I think it was relevant for all of us, because I think for especially for kids, I mean, SEG has many drawbacks also. I mean, especially in young kids. So I think quite a large part of all visible dysplasias still don't do SEG. We have one question from Vienna from Professor Rössler. So the question is it still possible to use the Montreal frame in the area of Jakob Creutzfeldt? Our hygiene department refused to sterilize it, and we had to change to disposal strips. So I don't know if you have issues with that in Brazil. I don't know if.
Yeah, we are trying now. Let me tell you this. We first of all, I could I could give you our experience. Okay, it's 33 years using no Jakob Creutzfeldt, so that's an important consideration. Second, we now are trying to develop with a company here disposable electrodes, because this has been the major major scenario preventing other centers to use these flexible electrodes. See, so now we're trying to organize this in a way. There's a company trying to produce this, because of course, if you dispose every time, it gets to be too expensive, just like you do with SCG. Then it would lose the appeal of something more cost effective. You see, but we haven't seen. We sterilize every time for 30 years. Never had any Jakob Creutzfeldt.
Well, a similar question from Dirk van Rost. So is there any advantage? And if yes, what is the advantage of the flexible electrodes for acute ECOG over the intraoperative use of strip or smaller grids? So
is that you can explore the banks of gyra and the depths of gyra, okay, during the ECG. So you do a first resection sometimes. And Eliseu, who knows very well, he's very good at going after that little portion of display that might have been left in the very bottom of a resection. And the flexible electrodes, you can go and put your electrode right there. Just the same, the first case I showed, you see, it had a small portion that didn't show up the other way around, that we in any other way that we could identify in that situation. See, so I strongly believe that the flexible electrodes allow you to explore much better not only the surface but the depths and the lateral banks of gyra, and that's where many times the most significant electro abnormalities are. That's the advantage I see.
Thank you. So. Any other questions?
Yeah, I have two questions, André. So thank you for your nice presentation. So what about the concept of the green spikes? So sometimes we use we always use the small grid electrode to start the ECOG, and then you go into the depth of the sulcus. You have a cavity like you showed, and then all of a sudden with our strip electrodes putting in there, the neurophysiologist in the room is saying, well, there are spikes, but I'm not sure if those are the spikes from the FCD or not, because you see the white matter on both sides. There is no abnormality seen but through the microscope, but there are spikes. And then our physiologists say, well, there is also a possibility of provoking spikes, so the so-called green spikes, and you should not chase those green spikes. Could you comment on that?
Yeah, I definitely would like to comment on that. I think that we have to understand historical facts into the historical context. Okay, now we have a different scenario than the 40s and 50s. At that time, you see, what would Dr. Penfield and Rasmussen would do? They would explore large areas of the cortex, okay? And they sometimes would find spikes all over. And they came with this aspect, this concept of green spikes. If you have spikes surrounding what you know was the lesion, because now you can see the lesion, they couldn't see lesions, you see? Even if they are not continuously spiking, we take them out. You see, it's not chasing spikes. Chasing spikes was what he was against when you had a large area of cortex exposed. But if you have in the vicinity of a resection spikes, I think you should take them out. The other thing is that he very clearly showed you what we showed you here, your neurophysiologist. Sometimes you can provoke spikes, but I don't think that provocation of spikes means that area is not abnormal. I think that area may be the part of the epileptogenic area that will not give seizures now, in the first few months, but they give you seizures later in time. That's my impression, you see. And sometimes you disinhibit that area with the first resection, and that's, I think, what he's seeing, and not something that is irrelevant. Let me tell you this. I got this scholarship and this grant to study exactly this now, because if you go in the literature, there is no paper really trying to put green spikes in the context of the 21st century. There is no such a paper.
Right.
You have some people from Colin Ferrier, I don't remember, I think it's King's Hospital or someplace else in the UK, 20 years ago, 30 years ago, you see, they have a paper saying, oh, maybe you can leave some spikes and that won't make a too difference in terms of outcome. But these are a series of 30 patients, 40, you see, you have to really put that into context of large groups of patients and take into consideration what you can anticipate in terms of histology, you know, because now, you know, for instance, if I have FCD2A, if I anticipate this, I don't have the transmantle, I don't have the bottom of sulcus, I have something a bit more like this patient of today, more widespread blurring. I mean, I wouldn't neglect to resect as many spikes as I can, because by definition, the biology of that lesion involves already something more widespread. I think that Professor Thomas, you agree with me that FCD2A is usually more extensive than FCD2B in terms of distribution of histological abnormalities. So I think that these spikes you're seeing probably have relevance, and we'll try to study this more formally now.
Right. Thank you. Thank you. And another question is the following. So in the FCD type 2B, you can have in certain cases this classical transmental sign. Well, we as epilepsy surgeons, we know that we not should chase, also again the word chase, the transmental sign. And our pathologist, he told me, I think he also trained a bit with Ingmar Blumke, that in the transmental sign, you only have balloon cells. You don't have dysplastic neurons. And that's the reason that you should not take it out. Is that true?
I think it is true. We don't take out that. You see, we take only up to the what I call the end of the calyx, because that's a calyx, certo? You know what I mean by a calyx. So you take out the area where you drink the champagne, but you don't need to get the stem, because even if you go after, if you believe in Professor Imar Najim's papers, that those balloon cells are mostly inhibitory cells. So they are on our side, let's say, okay, on the side of perhaps helping us to have seizure control. We don't take them out as well.
Okay, thank you.
If I may have a comment on what I think is really important what you're saying, because we talked about focal cortical dysplasia, but I fully agree with Professor Palmini. It's not one disease, it's a spectrum of malformation of the cortex that have different origins and different expression. For me, FCD type 2B are not a network disease at all. It's a lesional cause. So you need to remove the FCD by itself and only the FCD, because that's the cytomegalic neurons that are the pacemaker. We have a paper currently on this. If you take progenitor's neuron from a FCD and you put this progenitor in a mouse, the mouse will be epileptic because the neurons will be trained by the cytomegalic neurons. The balloon cells are silent on the electrophysiological point of view. I don't think they are involved in spike generation or spike control, but we mean something else. If you look at FCD type 1 or this kind of things, this is completely different. This is a network disease because this brain actually has the main canonical fasciculi that links these abnormal areas to normal brain, which is not the case actually in FC2B, which are a bit disconnected. The lesion by itself is not properly connected to the surrounding area with the U fiber. So it's really more complicated to integrate these interictal spikes because they will spread with these networks, and because also you have synchronization between remote area. And I had a provocative question actually to ask to Professor Palmini and to all of you. do you really think that FCD type 2A should be considered a specific entity, or don't you think that FCD type 2A or FCD type 2B, where either we did not remove all the FCD, or either the histopathologist missed actually the balloon cells?
Well, that's a very good question. I will start, and then I would like to see what our panelists would answer. But let me tell you this, okay? So I had this advantage of reviewing a paper that's coming out in epilepsy from Ingvar's group. I can say this because it's accepted now, okay? And they use artificial intelligence, okay? And to get many of the parts of the lesions, and they put that into this system, and they show that clearly many of the cases that you would expect to be only 2A, in fact, were 2B. You had some balloon cells. So I agree that there may be some patients in whom it's a spectrum within the same lesion of different histological abnormalities. However, I think that everybody has much better results with 2B than with 2A, okay? So that means that perhaps these patients with what we call 2A, even if they have some balloon cells and eventually would be 2B, would be a subtype of 2B, you see? Because maybe now we will move into subtypes of 2B, the ones that appear easily, as you mentioned, as a lesion, epileptogenic in itself, which is the transmantle, the bottom of sulcus, and this area, and this very, very obvious increased signals, and others where the balloon cells do not obviously lead to increased signal. Because some of this, there are reports, I'm sure you know this, of patients with 2B with normal MRI, okay? That means that the balloon cells in these patients didn't amount to increase the signal in FLAIR or T2. So probably there are patients with 2B that we believe are 2A and have some balloon cells, but this doesn't change the MRI picture, and the MRI picture is more 2A than 2B. This subgroup, even if it's 2B, it behaves as non-2B, if you know what I mean. So maybe what Professor Thomas is saying, that we may evolve into different subtypes of 2B if eventually this Ingmar Brunke's new approach of artificial intelligence will eventually show that even in patients we believe are only 2A, they have some balloon cells hidden here or there that doesn't show up in the first piece of tissue that's sent to the pathologist. That's what I think.
I think
Like to listen to what your colleagues think also.
I think we also all operated on patients with first diagnosis of FC2A that relapsed and that you reoperated, and with the second diagnosis of FC2B. That was really one part of the comment. On the other part is I'm really surprised that the same genetic mutation would lead to such close phenotype, and that still we are using this distinction between this.
Perfect. Thank you very much for the invitation again. Okay, I don't know if Danielle or Tom will close.
Yeah, I think it was really great. And maybe you have to rewrite the classification, I wonder, after this talk. So
I've done this classification. You see, you have to do one thing at a time in life. You do it, and then you go out of the picture, and then you do something else. That's what I believe, you know.
Okay. Good luck with the case today. Yeah.
If I may add a small comment regarding recordings, because I fully agree with the fact that not anyone can use SEEG. I fully agree also that there is a bias in the sampling of the brains, because you cannot sample everything, but there are clearly for me some indication where you cannot use something else than SEEG. That is, for example, the insula, because it really changes the game for insular cortex, and also for this, region on the mesial side, like SMA, that are very subtle on the MRI. But I fully agree with you that we need to take into account the economic situation of a region, what you have, and also not to be blocked on this intraoperative or perioperative recordings, because the best things you can develop is non-invasive mapping of the patient, and you mentioned high resolution EEG, and I think that's something really major in the field. And also high field MRI, I think is really something really important when appreciating this patient preoperatively. So, thank you. I was really pleased to meet you remotely, Professor Palmini, because I read your paper, and very, very pleased to meet you.
My pleasure. Thank you, Tom.
Thank you guys for sharing your knowledge, and thanks everyone for the discussion, and see you soon. Take care.
Thank you very much.
All
Tom.
right.
Thanks so
Thank you.
much.
Thank you very much.